So my name is Danny Jongevat. I'm a plastic surgery resident and a PhD student of Lenny Verkooyen. And I was involved, just like Joanna van der Velde and Maarten Burbach, in the three CMRCT cohorts in Utrecht. I'm also the first author of the stage-informed consent paper, and that actually brought me back to why we were here 2 years ago. So 2 years ago, all these different groups of people who started to adopt the CMRCT design came together. We didn't know each other in person, we only knew of each other, and it was so inspiring for us to be in the same room and start learning from each other. So it's great that 2 years later, we have all these papers, all these different papers from different groups that are accepted into these really high impact journals, nice journals. But also to see that, for instance, Linda's cohort, it was just an ID 2 years ago, and now you have over 1,000 patients in your cohort. And that's the same for us in Utrecht, but also to see Forbo, which was also just an ID that is actually starting to move forward. So instead of all these researchers coming together from their own islands, all of a sudden we're this united community of CMRCT or TWICs. So I think we should be very proud of ourselves for what we've achieved, all of us, in the past couple of years. So now that we've achieved some basis for this design and people are starting to notice the design, journals are starting to publish our papers, it's important to think about the future. So this session is a very open session, so feel free to pitch in at any time. We have a couple of speakers who will discuss some of the ongoing problems they've encountered during the last couple of years, and we're looking for your input to see how we should move forward with these problems, especially now that we're together with the CMRCT TWICS community again. So the first speaker is Joanna, someone whom I know very well. When she started the cohort in bone metastases patients, the doctors weren't very eager to participate in the beginning because they felt this is the most fragile population in our hospital. These patients won't participate in research, they're too fragile for this. So in the beginning, we were thinking that maybe 60% of the patients were able to participate, but Joanna has shown that the numbers are so high that no one was expecting this. So now that we have this population who is showing us that doctors weren't expecting them to participate, but they themselves are showing that they are actually quite willing to participate. Now that we have this fragile population participating in research, it's up to you to tell the audience what you've encountered and what current problems are in this population. So Joanna, I'll hand the mic to you and the floor is yours.
All right, thank you, Danny, for this kind introduction. So we were indeed able to enroll patients in the present cohort, this patient with cancer who has spread through the bones. And we weren't thinking that we are doing as well as the umbrella and the colorectal cohorts, but we are doing very well with enrolling patients. But now we are facing other problems, and I would like to use the next 10 minutes or so to give some background, and we can discuss these issues. So we treat many patients at our department for bone metastasis. Each year we treat 5,000 patients at our radiation oncology department, and 500 of them are patients with bone metastasis. So this is an indication how large this group is. And it's a very heterogeneous group of patients with a very heterogeneous pattern of symptoms. And also their survival ranges from several weeks even to a few years. As these patients face a limited life expectancy, our treatment goals are to reduce the pain that they have because of their bone metastasis and thereby improving their quality of life. We are enrolling all patients who are referred to our department or to the Department of Orthopedic Surgery. And this is the outline of our first trial within the present cohort, the vertical trial, because we know that after conventional radiation treatment, our pain response rate in this patient population is around 60%. So it's an effective treatment, but it's not that effective as we should like it. So that's why we are comparing the conventional radiotherapy to stereotactic body radiotherapy. We've pulled all phase 1 and phase 2 trials together, and their combined response rate was around 80%. So it could be a very promising new treatment modality that we can offer to our patients. But we have to, of course, test whether or not this is really better in a randomized way. So from the present cohort, we identify all patients who are eligible to undergo stereotactic treatment, which is the delivery of a high-dose radiotherapy to the target only. So it's very precise, very high dose. And therefore, we need an MRI, and we need several days in preparation for it, because we need more advanced radiotherapy planning time. So if patients are eligible, 50% of them are then offered the new treatment, which they can accept or refuse according to the CMRT design. This is how we have implemented it in our department. Patients are asked informed consent for enrollment in the present cohort by researchers in the so-called cohort clinic before they are seeing their radiation oncologist. Because we have to randomize them before they are going to the radiation oncologist, because the radiation oncologist is the doctor who is offering the treatment. At the cohort clinic, the researchers again check the pain score of these patients. It has to be 3 or more. They check again the condition of the patient. It has to be reasonable or good. And of course, they ask patients if they want to participate in the present cohort and if they want to be randomized into future studies, which is actually the near future, because we are randomizing these patients within 15 minutes or so. And if they're then randomized to the intervention arm, the radiation oncologist is then offering the treatment to these patients. But despite the extra checks we have built in our cohort clinic, we are still facing some problems. Because we have now randomized 53 patients, but after consultation with the radiation oncologist, still 9 patients turned out to be ineligible. For example, patients told the researcher they had pain, but actually their pain wasn't that bad, or their pain was in multiple places, so we had no target actually to treat. Some patients had impending fractures and had to be treated by the orthopedic surgeon first. So we weren't able to identify correctly all patients that we thought were eligible for randomization. So then we end up in the intervention arm with 21 patients, and only 60 patients accepted the treatment, which was also, surprising for us, because we thought these patients have pain and they want the best treatment they can have in reducing their pain. But as I told you, we need a few days in preparation for the stereotactic treatment, whereas the conventional radiotherapy, we can deliver it at the same day. So these patients didn't want to wait for the treatment. Then we had 16 patients who wanted to have the intervention and were randomized to the intervention arm, but we treated only 10 patients. So also in the time between the randomization and the delivery of the treatment, we lost 6 patients due to, for example, that they experienced neurological complaints and they needed emergency radiation treatment, which had to be conventional radiotherapy because we weren't ready to give them the stereotactic treatment. And if you compare these results to the trial we are also doing in our department, the rectal boost trial, which is in patients who are treated with a curative intent, they don't have these problems. They do not randomize patients wrongly. And if patients accept the treatment, they are really getting the treatment. So I think reasons for wrong randomization in our trial is that it is a very heterogeneous group with a heterogeneous pattern of symptoms. We have no multidisciplinary meetings before patients are getting referred to our hospital. So if a patient has an impending fracture and it is referred to our department, he or she is clearly at the wrong place. Furthermore, physicians write very concise referral letters, so it is not very easy for us to check the inclusion and exclusion criteria before we randomize these patients. And sometimes these patients doesn't have a very recent CT or MRI scan. And if we repeat that scan for treatment planning, we can see that the lesions are much more advanced than they were when they're getting referred. I think the early dropouts are because of the pragmatic approach we are having. So then I thought, should we stop or should we continue this trial? But then we had the luxury that we have a competing trial in the eastern part of the Netherlands, which is also comparing stereotactic treatment with conventional radiotherapy for patients with bone metastasis. And they started at the same time enrolling patients in 3 centers. So we are doing not so bad because they only selected 11 patients. And I think the patients who are randomized to the intervention arm are all getting the intervention arm. And I think that is an indication that they are enrolling a selected patient population more than we are doing.
It's recruiting from one center.
We are one center study, yeah, and they have 3, yeah. So maybe we should raise hands who should think we can continue with the study or who thinks we have to stop.
So the first question is, should we continue?
Or stop. No one dares to say that, yeah.
Well, I'll say it. I think you should stop thinking about this as if it was an explanatory trial.
Oh yes, absolutely.
No, but I think you're still thinking of it as an explanatory trial. Because I think, go back to your slide showing how many people. Like you talked about the people who were randomized wrongly. They weren't randomized wrongly, they were randomized correctly based on the pragmatic information you had at the time. And the people who elected to, who ended up unable to receive the treatment were people who were found to be unable to accept the treatment at the appropriate time. Those are not mistakes. Those are pragmatic, in line of care choices as your care is presently arranged. How you analyze the study is a different question. And I think that you may well, I mean, as a conscious analyst, you'll be thinking of this as both an intention to treat and as a protocol analysis. And that's a very good thing to keep both in mind. But I don't think you should see it as failed randomization or missed anything. I think that is what a pragmatic trial does. That is exactly what a pragmatic trial does.
Well, I agree with you that it is a pragmatic trial, but I think patients who have much more advanced lesions on MRI scan, they aren't eligible for stereotactic treatment. So maybe those patients are randomized.
Right, but they're eligible based on a typical clinical assessment. They only become ineligible when exposed to a much more in-depth clinical assessment, which is not available and nor is it going to be available to everybody at the front line prior to referral. So in terms of how your health system is now organized, they were diagnosed as eligible based on what your system can provide now and in the immediate future. And in that sense, it's a pragmatic trial. And then you need to play with the difference between the on-treatment and the ITT analysis. But I don't think you should think about it as wrong randomization or missed this or ineligibility.
It definitely sells better, right?
That too.
We have room for one more comment and one more question.
Well, I just wanted to comment. It really shows very nicely how much more information you get from Twix than from the festival.
Absolutely. Especially a classic explanatory RCT, where you take great pains to lose everybody right at the beginning.
And if I may add, I think it's also very useful to see if both trials are completed. So I definitely think you should also pursue the second trial in the other 3 centers. And then afterwards see what the generalizability of both the populations were. And so if you stop one trial at this time, then you would lose a lot of information on the efficiency of Twix, but also about, well, how generalizable your trial has been, your results are.
And I think you'll lose very valuable scientific evidence on the effectiveness of stereotactic radiotherapy. So I don't think you should stop.
Great, thank you.
Hi everyone, my name is Petter Viksven. I'm from Norway. I was so very fortunate to be the PhD student of Claire Elton and John Nicol, and I also had the luxury of doing full-scale RCT using the CMRCT design in depression, but that's not what I'm going to talk about now. I'm just going to very briefly present to you the project plan for my next project. Is this? So, very recently I've started a postdoctoral position at University of Stavanger in the southwestern part of Norway, and the plan here is to set up a mental health cohort for adolescents. And mental health problems are common in adolescents in Norway, as I think there are in many countries, and also they have a legal right to be involved in their own care. But there's very little research looking into adolescents' user involvement in mental health care. So we are hoping to set up a cohort, and our aims are to assess user involvement at individual and system levels, so for their own care, and also to improve healthcare systems, interventions, services, in primary and secondary care, and to look into satisfaction, effectiveness, cost effectiveness, and safety of healthcare services. And I also want to add to that, possibly look at the effectiveness and safety of user involvement on mental health outcomes. This is quite preliminary, but we're hoping to set up a population cohort. So that's all the kids, teenagers, age 13 to 17, 18, something like that, in the county where we live. And there's also previously been done some surveys in that region, and with a very high participation rate, over 90%, hoping to recruit them through schools. So for the ethical concerns, I think there are three key issues that I just want to mention, and I have more questions than answers to this, and even more after leaving this symposium. Two of them are TWIC specific, and one of them, the first one has to do with the consent process. So what are we asking consent for? And after having heard all discussions, I'm keen on trying to simplify the process and ask for consent once, and maybe an opt-out solution for participating in trials, or being selected to receive an offer of an intervention. But yeah, that's my opinion at this point in time. And then the second issue, I think, was John Nicol who mentioned yesterday that the use of social media. We know adolescents use them to a very, very high extent. So we're wondering, I'm asking myself the question, what will happen to the research once they start telling each other that they've been invited for this and that intervention, and how are we dealing with this, and what are the ethical implications of that? And then finally, there's a generic ethics question about informed consent. Age 15 and below, we have to ask the parents for consent, but I'm wondering, is there some way we can also open up for some of these adolescents to be involved in the research even without parents' consent? Because in some cases, the parents may not want to consent for very specific reasons that are actually affecting the child's health. So is there some way we can deal with that? So that's basically the project at this stage. Questions, or any input you may have, in particular on those three questions, but I think we've covered the first one. But especially maybe these two issues. I mean, any experiences or thoughts? Yeah.
You said it's a population cohort.
Yeah.
You're talking about mental health.
Yeah.
So how are you going to sell it?
We're looking at their mental health, but we're including all adolescents in the region. So it will be like they've done before. They have done it before in surveys, but it's not been as participants of a cohort, but they have filled in questionnaires about their mental health before. But the link between the individual responder and the data is cut. So we can't go back and we can't recruit them or ask them about, do a follow-up questionnaire. That's not possible. So we want to actually keep the link. So that's what we are asking for ethics approval for.
On the age question, I think you have the unfortunate problem that it's a legal question.
Yes, it is.
Which means that you either can or you can't in this circumstance. Now, of course, Norway is toying with the idea of going down to 12 years for valid research consent. Before that happens, I don't think that you can. I don't think there's any way to work around the parents at the moment.
Are there experiences in other countries where, yeah?
Well, in Canada, this is provincial legislation, and in Nova Scotia, it's actually no age cap off, but it depends on mental capacity.
Yeah.
So we have the interesting situation when, for essentially any teenagers, anyone between the age of 12 and 16. We need to repeatedly probe whether our participant has the capacity to make that decision for themselves. At which point we start replacing their parent consent with their own consent.
Okay.
So when we're going to see them, we often don't know in advance who will be consenting or whether we will need to repeat the consent.
So you're asking for consent every time?
Essentially, we started to do that, but definitely for this, we started to do it for everyone so that it's not confusing. But for this group, it's essentially mandatory, because if someone is coming, they are 14, and the last time it was their parent who consented, it's about 50-50 whether this time we will still be taking the parent consent as valid, or we will be asking them.
Is there any more input on this informed consent part before we go to the social media question? So for the social media, if I may start, the difficulty is, I think, quite similar to Forbo, that your control arm is the mutual care arm. Of course, it's actually no intervention.
Yeah.
I can imagine it being a problem if you go on social media. On the other hand, in your informed consent process, if you explain to the patients that they will be selected based on chance, and that it might happen that there are interventions where they are not even eligible, then patients who are not selected will not per se think, oh, there is an intervention and I have not been selected because based on chance, but they might just think there's an intervention that I wasn't eligible for and I wasn't selected. So that might also decrease this as an issue. But I think it's a difficult dilemma because on one hand, social media is so important for this group of people to reach them. So that's maybe one of the options to try to lower their expectations.
Yeah, we had the same question, or similar question, because the scleroderma community is very small, because it's a rare disease and people speak with each other at conferences, etc. They may share their information with each other, their login information, and there's just no way that we can control that. We were thinking about it and thought about whether it would be different in a Twix versus another RCT, where actually the exact same thing can happen and people can give each other's pills or swap pills, and we won't know. So I think one of the questions is this different from the Twix versus a regular RCT design? And I don't think it is necessarily.
There was another comment.
Presumably as well, your population of 30,000, the only ones that you would select to intervene is going to be a small number of that. If you're saying only 8% are diagnosed with something. So actually the proportion of people you're going to be pulling out to intervene with is going to be a very small proportion of your people. So your contamination is not as high as if like half of your population are getting something. It's actually going to be a few people dotted around who actually get the intervention, so it's hopefully less of an issue because it's a small number.
Okay, so I think we have to end this.
Thank you very much.
Remark.
Right, I'm Jana Zak. I'm a clinician working in the field of facial pain, and particularly trigeminal neuralgia, in which I'm an expert and have done several trials. Yeah. So it's a rare disease, at least classified as rare in the US. The Europeans haven't acknowledged it as a rare disease, but it's a unilateral facial pain that can be suicidal, and we have examples of suicides that have been committed both here and abroad as a result of this disease. So it's a problem, and it's also got a difficult natural history in that there are periods of pain remission, and so the quality of life does vary throughout the process of the disease. But we think it's probably a progressive disease. We've done, as yesterday was said, we've done all the systematic reviews, both of drug and surgical management in clinical evidence. We've even had a podcast and an article in BMJ about it. The problem is there are two treatments. There's drug therapy, which is purely symptomatic but gives big side effects. There are surgical managements which again are not curative but give much longer pain relief periods when they don't have to take their drugs. There are 5 surgical procedures which again have different risks and harms associated with them. And the problem is, what do we do and what are the challenges? Well, we've, for the first time ever, had a new drug developed. We've just got the phase 2 study, which we hope will be accepted in Lancet Neurology, and we're hoping to do phase 3 on an enhancement enriched design so that all patients will contribute to that. Timing of surgery, when we've looked at guidelines, we haven't got an idea of when should patients be offered surgery. At the moment, we tend to do it when the quality of life diminishes. The neurosurgeons are telling us if you do surgery earlier, then you have better outcomes, but there's no good evidence for it. And there are varying surgical options, and there's the natural history of the disease. So what I've been doing over time is I set up a cohort study knowing nothing about Twixes in 2007. I've now got a group of over 200 patients, which I'm just trying to publish the baseline data. And now I want to convert it potentially into a Twix, which is what Claire and myself have been thinking about and putting to the surgical community. Firstly, I've got a drug trial that I will be doing. Can I use, it'll be an enhancement enriched drug trial, international trial, both Europe and the US. Could I, and from this cohort, I will be selecting patients for that study, but could I use the others who are potentially not eligible for the study for one reason or another? Could I use them as my sort of control group as well? Because probably some of the outcome measures we're using here will be used in that drug trial. The other thing is, could we put patients through surgery earlier? And one of the options that we're talking about is, could we ask patients to go for early surgery? When I've gone to the patients to ask them, because we have a patient support group, they're saying, no, I don't think we want surgery early. You've got to show us the evidence that it's worth having surgery earlier. So if we were to try and randomize patients to earlier surgery, would we have a big dropout area, as we heard yesterday, that then it affects the quality of the data? And some patients don't want to have surgery, and there are 5 surgical options which have different harm. So I'm not sure, is this potentially a good design to do, and can I convert my observational cohort into a Twix?
What is the first question you would like us to answer?
Can I convert this into a Twix?
Is there anyone who's prepared to come?
Because at the moment, all I've consented my patients for is an observational study, filling out questionnaires at 3, 6 months and yearly timing. Unusual care.
The immediate thought is, yes, you can, but you need to go back to ethics and revise your concept form to reflect this. All right.
It's an option to go back to the patient and ask them for consent.
Yeah.
I potentially could. I mean, I've still got the patients are there. They're very good responders. I've just about got the drug company have agreed to help me do the survey, the annual survey, because they want to prove there's an unmet need for a new drug. So they're interested in funding a study.
So the other thing you'd have to do in your, to convert it into a TWIC is to make sure that your outcome measures for the cohort were at least comparable or useful for the trial that you want to run. So if you're going back to ethics to redo the consent, then you sort of want to make sure that they tally as well for your trial outcomes.
And somebody was talking about the package of questionnaires, which sounds a good option, which I think is the one I would go for to ethics.
I think on converting it into a Twix, you have two ways of doing it, it seems to me. You could first randomly select a group of people who are eligible for this drug and approach them as if it was a full randomized trial, and go to the other patients who are not selected randomly and ask them for consent to use their data. Or you could go back to everybody and do a normal Twix consent and then approach. So I think there are two orders, and I'm not sure which one works better.
Yeah, I mean, my comments, you're worried about the surgery. What's the downside?
Yeah, the problem of surgery.
Yeah. So what we're all talking about is, in Twix, is randomization before. It's that you're not told to what you're going to be randomized before you consent to it. That's a key part of Twix, not some other designs. And you just said that that's going to be a problem because a lot of patients just aren't going to want surgery at all.
That's right, whereas others might decide, yes, it depends on their quality of life at the time I approach them. Because sometimes they feel suicidal, they come into the joint neurosurgical clinic and they say, oh, surgery tomorrow. And other times they come in and they say, yeah, I want it tomorrow. And then 2 days later, they've gone into remission and they don't want it. So I've got that change of the natural history.
So you've obviously got yeah, so I mean, you've obviously got a major disadvantage. You know, you've got to stop thinking of like, well, Twix is just one thing, right? Now, either we're a Twix or we're not. Should I convert this into a Twix and say, well, there's various advantages and disadvantages, and there's various methodological approaches here that are going to be useful or not. And what strikes me is the methodological approach that you can take from Twix that's going to be useful is you're getting a lot of data anyway. I think the methodological approach that is not going to be useful is the randomization of patients without them knowing to what they're going to be randomized, because I think you're going to have problems on both arms doing that.
Yeah, because surgery, there are only 3 randomized controlled trials and they're all on technicalities rather than the trials themselves.
For the sake of time, the last question.
Yeah, how long is the planned trial for the drug?
It's going to be probably 12 weeks because there's also an extension after completion of the randomized control trial. There's an option if you were a responder to have the drug for a year, because in phase 2 we couldn't recruit because they had to go back to their old drugs.
And you would have to do that blinded.
Yes, that section.
Okay, so you're only talking about Twix for surgical intervention?
Possibly.
There's a lot of details here because since you can't do Twix with the blinded requirement, so I'm just trying to get a handle on precisely what the trial would look like, regardless of whether you could do it. But that was my question.
I would say that you need to sort of think long term over the next 20 years. What are the questions you want to know? Prioritise them now, and then the design will follow on that. So, cool.
Right. Thanks very much.
The question I've got is, we are planning to set up a special panel to give endorsement for registries that are specifically for recruitment of patients into research. So that includes a sort of consent for consent or consent to be approached registries that exist. Some of them are disease specific and some of them are sort of trust based. I think we might have a few national ones now as well. I'm just sitting there thinking, should we be putting cohorts into the panel? So the thing about endorsement is it's not a requirement. Nobody has to come to us for endorsement. But the beauty of having the endorsement is that when you take individual studies to a rec, they won't look at the recruitment process again because it's already been sort of endorsed by the HRA. So they would just look at the study but not ask questions about how the patients are going to be recruited because that bit has already been covered in the endorsement. So would it make sense to take cohorts into the endorsement process of this panel? I can see for something like the South Yorkshire cohort where you've got a very big cohort and you're going to be doing multiple studies over time, it could make a lot of sense. And maybe for some other smaller ones it wouldn't make any sense. I don't know. So open that up.
When I did my presentation yesterday, you saw that I had registry/TWIC studies. And the reason I combined them was because I wasn't very sure what the difference was between a registry study and a TWIC study in which the register is defined as a group of people in the cohort. I'm not sure, I couldn't find the difference.
There's starting to be a crossover, isn't there, I think?
I think that comes back to my prior point. I mean, it drives me nuts when people say, well, is it a double-blind trial? And they say, well, here are the people who are being blinded. And they're, well, is it double-blind? You know, we can't fit things into these neat categories. We've got to think, what is the methodological technique we're using? And does that introduce bias? Does it cause problems? And, you know, rather than twins, it's not twins, it's registry.
So if we did that, for those of you in the UK, would that be a helpful approach?
Is there someone who disagrees?
Well, I think lots of people are thinking about setting cohorts up that are open-ended in terms of there's not a finite number of RCTs they're planning. For those people, it's clearly advantageous to have a time endorsement.
Okay. Yeah. So what we're drawing up some principles to support the panel. So what I might do, if that's okay, is maybe circulate the principles for those that might be interested. Yeah. Okay. Thank you. That's useful.
So what I'm talking about is I want to talk about framing, and it goes back to behavioral economics. A lot of times we spend, well, what are we going to say to the ethical committee? What are we going to tell our patients? And that's the way in which we do it isn't based on any theories or principles. And then I want to talk about the harm from informed consent and whether we can think about that as moving forward in ways to motivate things. Okay, so this is the classic example of framing is that, you know, Sister Teresa is saying, oh, you know, the Mother Superior, I'm really pissed off. Mother Superior said that I couldn't smoke when I prayed. And, you know, her friend Sister Maria said, oh, that's odd because Mother Superior said that I could pray when I smoked, right? And there's all sorts of examples of this that you can say things in lots of different, the same thing in two different ways. And our big problem is how we've been talking about ethics and TWICs, and I'm way more guilty of this than anyone is. What we've been saying is, if we change the ethics this way, or we do the randomization in a different way, it's going to help me as a researcher, right? We'll get more patients on trials, and I'll get a bigger study, and I'll be in the BMJ, and it will be great for me, right? It's this sort of selfish thing. And it's just generally not worked with ethical committees. You know, when I've gone with them, and I said, look, it's much easier to do this. Now, I genuinely believe that a lot of the novel ways we have of thinking about consent and thinking about randomization and doing things differently in terms of the consent are actually better for the patient. Okay, now, if you remember this, do you remember this film, No Country for Old Men? This is an absolutely terrifying scene where this psychopath goes into and says, call it heads or tails, and if you get it wrong, I'm going to kill you. It's absolutely terrifying, right? Everyone remembers that. But I mean, this is just like, you know, every day at Memorial Sloan Kettering, you know, this is what we're doing. We're saying, well, we're going to flip a coin, and you're either going to get surgery or you're going to get the, you know, the therapy. To help you decide that you've got a 17-page consent form. And it goes on. I mean, this is 4 pages of risks like this. Right? This is a completely traumatic experience from a patient. And you know what was interesting? I got a friend of mine who's a general practitioner, and I asked him, tell me, do you have any patients on trials? And he says, what happens to me all the time is I have one of my patients, they're dying of cancer, they get involved in a trial, and they come back to me, and they're devastated because after all this crap that they go through, they get randomized to the best supportive care, right? Which means you know, this is what happens. You've gone through your chemo, the cancer's still growing, we're either going to send you home to die, best supportive care, or you're going to go on this new exciting agent, right? And they go through all this hell, and they're bitterly disappointed. It's really, there's a lot of problems, a lot of distress. It goes on and on and on, by the way. So we're asking patients to make this decision, do you want to go on this trial or not? And that causes cognitive burden. It causes conflict, what should I do? That induces anxiety in patients. They're worried about now what to do. Then you get something called decisional regret. You've made the decision to go on the trial, and oh, maybe that was a bad idea. Or the worst thing is, you know, look, I just can't deal with the trial anymore. And then you're thinking, oh, geez, maybe I should have gone on that trial. And then there's this aspect of confusion. You say, well, you know, I'm really come to terms with my situation now, doctor. You know, I know my life is short. I really want to spend it with my family. And then they come along and they tell you about this fantastic new drug. And like, well, great. Why don't you give it to me? And like, oh, well, we have to do a randomized trial. And that's very confusing for patients, right? Why, you know, this, you could save my life with this new drug, but you're not going to give it to me. And then this issue about disappointment, that, okay, I didn't get the new drug, now I'm very disappointed. This was my one chance to save my life. And all of this is in this context of extreme information overload. So we're often doing these trials at this terrible time in a patient's life when they've all these other things they've got to deal with. I do surgical trials. Patients have just been diagnosed with cancer, and we're telling them about their treatment options. And if they choose surgery, there's a 78-page booklet about, you know, catheter care and wound care and coming off Coumadin before. And we're asking them, and then, you know, on top of all that, we're giving them this like 17-page consent forms. And my own view is that there's an idea that the more information you give people, the more informed they become. I think after a time, then it ducks down again, the more information you give them. And patients, I don't know what your experience is in the consulting room and watching patients, but it tends to be after a certain point, they're like, it's just too much. I just don't want to deal with it. Or look, hang on, just doctor, what do you think I should do, right? It actually causes a regression with less autonomy when you give all this too much information. So now let's look at a typical design of the sort of thing that we're doing is that, you know, you're randomizing the eligible patients, and if they're in the control group, you just say, well, I'm going to give you the surgery, and here's your consent for the surgery. But if you get randomized to the neoadjuvant therapy, well, we've got this new treatment. Would you like this new treatment? And then they get the research, they get a research consent as well as a clinical consent. Well, what happens if you do that? Well, the thing about making a decision and all that burden and anxiety, and should I go on the trial or should I not go on the trial, and all that is reduced by half, because half the patients are never having to face that sort of decision. The information overload is reduced by 50%. Because what we're doing is we're sitting and explaining all these side effects to patients, on and on, and well, what do you mean diarrhea, you know, and on and on, and 50% of the patients are never ever going to get subject to that side effect anyway. And then, of course, confusion, why can't I get this treatment? And, oh, now I'm really disappointed I didn't get it. You're eliminating completely. So this is an awful lot of patient distress that I think you could eliminate by changing the way we think about doing consent. And so we can reframe this whole thing. So I genuinely believe doing this sort of trial is going to relieve a lot of distress amongst an incredibly vulnerable population who, frankly, have got enough on their plate. I mean, look, I come from the cancer world. So I know there's probably similar things in some of the other diseases that you guys deal with. So can we reframe it like that? There isn't very much. The problem is there isn't much empirical data. I'd love to say, oh, look, here's all this data showing that the standard consent is very, very distressing. So this is going to be an empirical base for saying we need to think again about distress. This is pretty much it, this one trial in the British Medical Journal in 1986. I don't know, there's a variety of different endpoints here, but one of the interesting ones is the anxiety. This is the state trait anxiety inventory. Does anyone know that scale? These are incredibly high, right? And if you look at the difference between the two, I mean, you know, and this is just by changing the type of consent, you're actually causing clinical anxiety in a very large number of patients. So this is what I put in a grant to do. I'm planning to do it. If other people are interested in this type of research, let me know. Let's talk to patients who've been approached for participation in a trial, whether they took part or not. You know, and we do the focus group, and we have qualitative researchers. What was our qualitative research? So there you go. Talk to them. Tell me about it. You know, did it make you depressed? Were you anxious, and so on? And we design some kind of survey instrument, and then you do your standard psychometric study when you evaluate the properties of that instrument. So, you know, does it distinguish between a trial in end-stage cancer and a trial of, you know, music therapy for mild depression or something? I don't know. You'd expect there to be different levels of anxiety associated with those two trials. So what I hope to do is say, let's reframe this debate as something, let's do this research because it is actually better for the patient and because I actually genuinely believe that to be true. But we also need to document that. But where are we going for this? Can we use harm to motivate Twix approaches? And I'm a little concerned about that because I believe that we could reduce the distress, we can reduce the harm and still maintain patient autonomy. But I think many in the US, there's this incredibly expansive view of patient autonomy. Unless you're telling the patient absolutely everything about everything, then you're reducing their autonomy. And I think that the classic example of this is that you've got these 17-page consent forms, which I think are brutal for patients, and that's seen as good. And if you say to a patient, I'll give you $5 for filling in a questionnaire, that's seen as kind of coercion by many. So I think I think there's going to be two battles we're going to have to fight, right? One is to demonstrate that there is harm and that it can be alleviated. And secondly, to actually say this is a bad thing. Because I've had people say to my face, or in written communication, ethicists say, that pain and suffering from patients, that's just part of life. And there's nothing we should do about it, because that's just being a responsible and rational human being. But anyway, I really appreciate comments on that, all that.
So, for the sake of time, I think we're going to go for three, in this case, three comments.
I think that the disappointment, I think this is really interesting. And I agree.
Can I get your number?
Huh?
Can I get your number?
Of course, yeah. No, this is super, super interesting. I think that there may be a way to do this, but I'd have to know some more details. For instance, the disappointment issue, I agree with all the burden stuff, and just reducing all that except the disappointment even would be a tremendous advance. Right. The problem that you're going to run into is that if you do this with only cohort consent, or no cohort consent, and then we get back to the Zalen.
No.
Okay. If you do advanced pre-randomization, whatever, there's going to be a certain amount of disappointment because they're going to know. I mean, look, if I'm going to go to Memorial Sloan Kettering, if you never call me for a trial and I don't have much time to live, I mean, I'm going to be pretty pissed, right? So I think that part, it's going to be very difficult to get around. However, I do think that there's something, it's a softer landing perhaps, right? If you don't go through all that and then told, well, you get the regular treatment, versus just not being called up to do whatever. And then the rest of it is you can argue for a pre-randomization broad consent. It spares the people of all that stuff. Yeah. I think you could make that argument.
Yeah, I take your point, but what we could do in a Twix context is, will there be another trial which might be a drug to help end of life anxiety, right? Or they wouldn't be eligible or something, but it certainly reduce it.
There's room for one quick comment.
All right, my next meeting's at 5, so I'd really like you to stay and chat to me afterwards.
Some of this during the panel discussion.
Yeah.
This is an ethical issue. So one more comment.
Yeah, I'm sure you've already realized that there's also a way to remove 100% of the suffering.
It's not a trial.
No, which is not asking anyone ever.
Yeah, but then that doesn't maintain the autonomy. I'm saying, can we reduce a lot of that suffering and maintain autonomy? If you think of a way of reducing 100% and maintaining autonomy, please let me know.
So
right?
That's a very good point for the discussion, panel discussion that we have.
So this question about distress and efficiency has been really interesting me for quite a few years, and John Nicol as well. So finally, there was a HTA call by the NHR for efficient study designs. And we thought, well, we've got something we think might be a bit more efficient, but we don't know. So on the back of somebody else's trial, we added in what was called a methodological bolt-on study. So this is a trial that went to the HTA for funding, and they were asking for methodological bolt-ons. So we were the methodological bolt-on, and we called it the informed consent trial. So a randomized controlled trial of the efficiency and acceptability, and that could include a whole load of qualitative stuff as well, of 2 different informed consent pathways for effectiveness trials with usual care comparators. So we put this in. So let me just describe it a little bit more in detail, and then I'll tell you what happened to... Oh, what happened there? There we are, yeah. So the aim was to compare the efficiency, etc. So the objective, we called it standard informed consent, so telling everybody up front, etc. And then the tailored disclosure, I think the patient-centered, there's loads of different ways, relevant, adequate, whatever. But the alternative approach to informed consent that we've been talking about. And we decided to measure efficiency by actually comparing numbers analysed to the numbers approached, numbers analysed to the numbers randomised, numbers analysed to numbers that allocated the intervention, numbers who comply, who accept their allocation. So basically, you know those consort diagrams with all those numbers? So the idea is we would approach a large population and we'd randomise people to either be approached to have the standard approach to being in a randomised controlled trial, a pragmatic randomised controlled trial with treatment as usual or the comparator, or they would be randomised to a Twix approach. So, hey, do you want to come into a cohort with this condition, and then da-da-da. And we just look at all the numbers, we'd look at all the time it took, we'd look at the cost of everything, and then we'd look at the quality of the people recruited in terms of their representativeness of the target population to whom we're actually wanting to generalise the results to at the end. So we really enjoyed designing this actually, and yeah, we were going to piggyback it on one particular trial. So I can't remember. I composed these really. That's the next one. So I'll tell you what happened. So the proposal went into the HTA board. The HTA reviewers really liked the methodological bolt-on study, but the methodological research was actually going to be funded by the methods research panel, the MRP panel, and they tore it to shreds. They said it was too expensive, which I think it probably was. But so that was they had 2 main criticisms. The second one was, wait for it, they thought it wouldn't be approved by an ethics committee. So it was bounced out, and so they were prejudging what an ethics committee would say when there's actually historical precedent for Twix designs being, because it's actually a Twix design. The whole thing is a Twix design, because you wouldn't tell people, hey, you're actually in an alternative method of being recruited to a trial, because that would be meaningless. So yeah. So yes, I was deeply wounded by this for about 3 months, and then I thought, hey, come on, this is still a good idea. So when we were composing the program for this, I thought, okay, I'll come and bring it out again, and had a couple more discussions with my colleagues. And I think it was one of the reasons why I actually came and talked to Amanda and Clive at the HRA, was thinking, okay, well, ethics committees, you know, how would they approach this? Is there a way that we actually could send this back to the MRC, the methods panel, and say, actually, well, we know what the ethics committees are going to say because we've gone and talked to them. And then the other thing we thought was, well, rather than piggyback it on one trial, which was actually, it was a trial of an intervention in the elderly, would the results from this particular methodological efficiency and acceptability study in an elderly population, would it be generalizable to a young population or adult mental health? You know, we thought, well, actually, maybe we need to do a sort of range of trials within trials, or trials of trial methodology. So I guess a few months ago, what my thinking was, and it's still evolving, was actually seeing if we could recruit, say, 5 or 10 clinical trials units in the UK who would say that the next time they get somebody coming, a researcher coming along with a pragmatic trial design, that they would offer a service where they would say, actually, well, we're going to do a methodological study alongside what you do. So this is your research question, this is your target population, but we're actually going to try 2 different ways of approaching and recruiting and informing and consenting people. All the inclusion and exclusion criteria will be exactly the same, the outcomes will be exactly the same, but who you tell what, when, would be different. and then we compare the efficiency and acceptability. So that was my sort of idea. That was my latest idea, was actually maybe 5 or 10 clinical trials units with maybe 5 or 10 studies over 5 or 10 years, maybe 5 years, where there'd be actually an efficiency and acceptability piece of research on the back of it. And if you did it, if you did all those at the same time, it would mean like a few meetings with people and setting things up. But once you've got the first one rolling. So that was my idea. So I guess I'm looking for people to shoot it down, refine it, or offer to collaborate, or directors of clinical trials units or recs who want to help. So.
But yeah, the comment, by the way, there's been lots of randomized trials on consent.
Yeah.
So I thought that's a really bizarre.
Yes.
I mean, they're all on knowledge, right? Do we do it this way? And the only endpoint they look at is knowledge rather than an understanding, rather than sort of distress and participation so much. But yeah, I thought that's a bizarre comment.
Yeah, well, they said that initially, and we resubmitted it, and they still just said it again. I mean, we put very logical arguments in there still. So, but I think it's. If anyone's got any ideas, cute ideas on thoughts, comments.
My experience doing piggyback studies, which is what you're describing.
Well, I suppose it's parallel, isn't it? So it's the same research question, but looking at it from two perspectives.
Well, I understand, but the PI of the study has to be comfortable with what you're doing with his trial, so to speak. So I was just going to suggest that developing a relationship beforehand when you hear of it, so that you go in it together rather than you approach them after they've had their study designed. I just find it I found it very difficult if they already have their set ways of thinking for you to add this great ethics piece on top of it. There's because they don't want to compromise their study.
I agree. So thank you, Scott. So one of the collaborators on this is David Torgerson, who's director of the clinical trials unit at York, and he's said to me on countless occasions he doesn't know which is the best way of providing informed consent. But what he tends to do is he tends to do the standard one because he knows that'll get funded. But genuinely, when you talk to him, he's openly admits he doesn't know which is the best approach. And that's a director of a very successful, prolific clinical trials unit. And I think he's not the only one, because we don't have the evidence base for the research decisions that we make around informed consent.
The one thing I think that might be a problem here is, are you going to choose sites to randomise to standard tailored intervention, or are you going to use individual patients? Because you might then have two different methods of consenting within a site, which might be very confusing.
Yeah, I think it depends on the research question and the population, because basically you've got to create a cohort of people who would be eligible to be approached for either design and then randomise them. So I think it would depend very much on the context, but yeah, it would need thinking through quite a lot.
I quite like the idea, but I can't quite see how it would fit into the current framework of trying to get clinical trial funded.
Yeah, I don't think it would cost that much more, actually. Basically, you'd need, a body who would go around with the expertise at certain key points in the decision-making between the research and the clinical trials unit, and then the ethics committee meeting. And then we've got lots of examples now of how to do the information and consent for the Twix type designs.
So one final comment in the back.
So I was only going to say that a lot of trials units are the same.
Yes.
So York's I work in Leeds, I know York, and York as the trials unit don't do a huge number of drug studies.
Yeah.
They do interventional, it's not causing drug, it's just through. Whereas in Leeds, their trials unit does hundreds of drug studies. They would run away screaming initially, I suspect, this because they're used to working that very tightly regulated, we control everything from start to finish. So I think it's a really interesting idea, and I think that's one of the things I'm really hearing today about what does consent look like. Finding the right trials units will be key.
Fundamental question, sorry if I missed this. The tailored pathway, that's a Twix pathway?
Yeah.
I wonder if there would be an opportunity to find a traditional RCT and convert it to a Twix and see if the accrual numbers change dramatically.
actually converting halfway through, or what?
Yeah, I suppose somebody's running a trial of some behavioral intervention with a conventional recruitment approach. And there's an existing Twix cohort, one of the ones that's already been built. And you could start recruiting for that trial within the Twix cohort. And you could compare how the accrual statistics change once you do that.
That's a nice idea.
That is actually what we are going to do in the Netherlands.
Okay.
We were approached by a trial in colorectal cancer patients. It was an adjuvant chemotherapy, and it was in a classic RCT where it was just not working. So they approached us, knowing that we have this cohorts, and well, we're going to see. I mean, it's only.
So you're doing it. You're doing it. Brilliant.
Going to do it.
Brilliant.
See where that's going to be.
Okay. Well, if you're interested in having a look at how we were thinking of doing the evaluation, then I can bang it over to you. So.
Find a multi-site trial and randomize a multi-site trial which is failing to meet its recruitment and randomize the sites to.
The thing you'd have to deal with in that is that generally when you have a trial that's designed for a particular purpose, the case report forms out of control because everyone's pitched in at the design stage, and so there's tons of prompts, not just the sort of the core sort of outcomes that you'll have on a lightweight in terms of burn kind of cohort. So it'll mean sort of ditching lots of prompts, which ethically is fine. Ethics is usually fine about losing sort of procedures, not adding them, but it might upset some of the scientists, and they might be people who say, oh, well, we don't want to lose all those prompts.
So wow, there's some really great ideas there. Okay, I've got 3 more ideas, but I'll whiz through them because we've got the panel coming up. So the next one I just mentioned in the introduction was I would love to get a group together to apply for some funding to actually introduce an extension to the consort statement that actually reports informed consent for trials. So who says what to when? Using the methods used for the extension, the consort extension for pragmatic trials, I think they've done fantastic work. They've moved things forward. That's fantastic. So that is just woefully, there's a big space here that needs to be filled with who told what when. So there's an example. So if anybody's interested in collaborating with me on that, then please come forward.
Just a little flag, right? The consort is everything's very simplified down, right? And it's you just must say something about this one issue. And I think a lot of things in the consent, certainly like psychological trials or behavioural trials, exactly what words you say are really, really critical.
Yes.
And so the most you're going to be able to do is, were patients told to what they were going to be random. It's very difficult how you can have 3 or 4 things that are going to be simplified.
I think it's doable. I think it's doable.
Yeah.
I've got some drafts that I can share.
What I'm saying is that having sat on this, I did sat on tripod, and everyone wanted this very specific thing that would answer their methodologic question, and they were like, no, that's not what we do. We answer these very, I was, let's do decision analysis, and they're like, if whatever technique you use, describe it, right? Was what ended up at.
Okay. So just briefly, another proposal is. So we put in a bid to EDAG, the Early Diagnosis and Advisory Group, which is sort of part of Cancer Research UK, and the idea was they wanted to do some work around evaluating the cancer awareness campaigns in the UK, which at the moment just use some street surveys and then prescribing data and GP visits, so it's very far from actually what they're wanting to measure. Which is actually impact on the incidence of cancer and cancer awareness. So we said, okay, well, we've got our Yorkshire Health Study with 30,000 people in, but there's a lot of other cohorts and registries in the UK that if we actually join them all together, we could actually do a really good UK evaluation of the cancer awareness campaigns. Because at the moment the cancer awareness campaigns come out and they're just, well, let's do it here for 3 months, let's do it there for 6 months. There's no clear plan. So we didn't actually get that funding bid, but the Population Research Committee really liked the Twix idea. So they're very keen, and they're courting us to actually put back a bid that actually will fit their call and go for a 3 to 5 year program. So if anybody's interested in looking at Twix and cancer and putting in a bit of Cancer Research UK, again, you know where I am. And then the last one is I know that the Global Challenges Research Fund, which is a stupid number of £1 billion coming out of the UK for a budget, I believe, that there is going to be a call around methodology for research in low to middle income countries. So that may be a possible opportunity. So those were the 4 things I just wanted to mention. So again, if anybody's interested, let me know.